may need regular follow-up if they have symptoms, especially. Atrophic round holes within these lattice do not require treatment because there is quite a low risk of progression to retinal detachment if there's no and especially if there's no history of retinal detachment in either eye. If there is a history, then maybe you might want to treat. So retinal detachments are caused by posterior vitreous detachment associated with horseshoe tear, and usually they occur at the edge of the lattice. So it's difficult to know how much to treat. So operculated retinal holes, if they are atrophic round holes within the lattice with subretinal fluid, generally are not required to be treated. Norman Bayer found that only 3 cases out of 423 retinal detachments in lattice eyes with atrophic round holes. Also, very few asymptomatic operculated retinal tears cause retinal detachments, and none of them actually progress to retinoschisis detachments. So there is a small chance of asymptomatic retinal tears progressing to retinal detachment, so only 5%. It's not a high risk. So I mentioned these 423 eyes in 276 patients, 35% had atrophic holes in lattice, and 10 eyes of 150 eyes had subretinal fluid associated with it. But only clinical detachments occurred in only a small number, 3 out of 423 eyes. So basically, there is no effective method of prevention of retinal detachment. You have to educate patients at high risk of developing retinal detachment and advise periodic follow-up depending on the nature of the lattice and peripheral degeneration. So what are the groups of people you should be most aware of? Of course, myopia is probably the main risk factor. And high myopia increases the risk of retinal detachment by up to 10 times the normal population. But still, there is no evidence that treatment of asymptomatic lattice or retinal breaks in high myopia is of any benefit in preventing retinal detachment. The only some studies have reported after cataract surgery, if you are high myope after cataract surgery, and there is an increased risk of retinal detachment in patients with high myopia undergoing cataract surgery. And in those patients, if you do see significant peripheral retinal degenerations, you might want to treat them, either atrophic holes, tears, or lattice. So it's important. So what about management of retinal breaks and degeneration in phakic eyes? So basically, the recommendation is there is evidence for the treatment of symptomatic retinal flap tears, because we know that 50% of these tears will lead to clinical retinal detachments. And treatment reduces this risk of retinal detachment substantially down to about 5%. And the most important symptoms, of course, we are all aware, the acute onset of floaters and flashes. So if a patient presents acutely with these symptoms and you see a presence of a retinal flap and U tear, then you must institute the laser photocoagulation. For asymptomatic tears and holes, the risk of retinal detachments is very low, as I mentioned earlier. It's 0.5 over 11 years. And even lattice, cystic tufts, degenerative retinoschisis, the risk is all less than 1% over long periods of time. So after uncomplicated cataract surgery, the risk of retinal detachment is 1 to 2%. All right, so even uncomplicated cataract phacoemulsification, 0.8 to 1.3%. Okay, of course, in the presence of complications like posterior capsule rupture, vitreous loss, and in high myopic patients, the risk goes up significantly. And also, if there is already a history of retinal detachment in the fellow eye, then there is an increased risk of retinal detachment following cataract surgery, even in uncomplicated eyes. So prophylactic treatment before cataract surgery may reduce the risk of retinal detachment in some of these eyes, and this has been shown in some studies. It reduces from 19 down to about 8%. But just bear in mind that the tears that lead to retinal detachment usually occur in previously normal areas even in these untreated eyes. So sometimes it's impossible to treat the entire peripheral retina, so the risk of detachment is not really reduced to zero. What about LASIK, laser refractive surgery? Already myopia is a higher risk of having retinal detachments. It's a high risk anyway, so already risk increases by 10 times. So no evidence so far that retinal detachment rate is higher after LASIK, okay, but there was some, if you read the literature, some papers suggest that LASIK induces more acute posterior vitreous detachment because of the pressure rise during laser surgery, and that might induce earlier posterior vitreous detachment that otherwise would have occurred, okay. So that is the main risk factor. So prophylactic treatment of peripheral retinal degenerations and tears prior to anterior segment surgery. Do we have any good evidence? And we know that actually there's very little evidence so that we can go by. So you have to evaluate on a case-by-case basis, all right? And depends on your practice and your the guidelines set up. So what about fellow eye or patients with retinal detachments? So fellow eyes, if you see enough retinal detachment patients, you will see that they always often have the same vitreoretinal pathologies in both eyes. Okay? And even in the absence of retinal detachments, retinal breaks can occur up to 19% of the time. Fellow eye detachments about 10 to 15%. But again, there's no good evidence that treatment of retinal pathology in the fellow eye gives benefit in preventing retinal detachments subsequently. Okay. For example, lattice in fellow eyes in patients with retinal detachments, because basically new tears often occur in untreated, previously normal-looking retina. So the U tear doesn't occur at the lattice; it occurs somewhere else. But because we always warn patients about retinal detachments, and probably many retinal surgeons do treat fellow eyes of lattice degeneration anyway, okay? Especially if the outcome of the retinal detachment in the affected eye is poor. So if there's one single good eye, then you might want to treat them as well. But in aphakia or pseudophakia or impending cataract surgery, the risk of retinal detachment rises a lot. Of course, we know that, especially when it's complicated surgery. So once you see flap tears, you should treat them, even in the absence of retinal detachment. And but if you see lattice or round holes, probably do not need to be treated. You can watch them and keep the patient advised. Okay. So what to do for fellow eyes of a patient with retinal break or retinal detachment? Depending on the risk profile and the factors to consider are the symptoms. How high is the axial myopia? The state of the posterior hyaloid, the status of the eye in terms of phakic or aphakic, and the type of retinal lesion that you see will determine the risk profile for individual patients. So if you can have this sort of differentiated, then you can advise properly the patients in terms of treatment. All right. Of course, higher risk if they are symptomatic for floaters and flashes, if they have high myopia, in the absence of posterior vitreous detachment, aphakia, if they're already aphakic or pseudophakic, so a flap tear or tear with some evidence of subretinal fluid already, and retinal traction, and lattice degeneration with breaks. Okay, so the question here is that if there is no posterior vitreous detachment, is a high risk for the future because posterior vitreous detachment is going to occur sometime, and these lesions may predispose to higher risk of retinal detachment. If you already see that the patient has a posterior vitreous detachment, conversely, then you know that the risk of subsequent acute PVD is already reduced, then the risk of having further tears in the retina or further risk of retinal detachment is much less. So that is the rationale for looking at the state of the vitreous. It's very important. Okay. So if there's no evidence of clear evidence of benefit, so obviously we treat flap tears, especially those are symptomatic and not necessary to treat lattice with or without atrophic holes. So you understand that the evidence is not complete in terms of actually how to treat them. We only have longitudinal studies that have followed patients for long, but no real randomized controlled trials to guide us. But bear in mind, the risk of detachment is not overwhelmingly high, even in patients who have high myopia. And, I mean, we know the incidence of retinal detachment in the general population, 1 in 10,000 or 10 in 100,000. Okay, so not that high. Prophylactic treatment does not totally prevent retinal detachment. So you have to base it on the symptoms and assess the eye, especially if the patient is going to undergo cataract or LASIK surgery. So you have to assess the peripheral retina with the indirect ophthalmoscope, binocular indirect, of course, and there are various lenses depending on the state of the pupillary dilatation and the magnification you want to use. And it's important to examine the patients in both the sitting as well as the reclining position. So this is an essential skill if you want to be for vitreoretinal surgery and for managing vitreoretinal patients. You need to have the skill, and sometimes learning how to perform indentation will delineate the lesions better, and especially in eyes that do not have wide pupillary dilatation. So you may need to indent to see the lesions and characterize what type of lesion you're actually looking at. Besides the binocular indirect, you will assess on the slit lamp as well, and you use a contact lens. Of course, in the past, we use a lot of twin mirror lenses, but nowadays, I think most of us have prefer to use the wide angle view contact lenses. For example, the quadraspheric lens gives you a wide enough view up to beyond the equator to the aura. Okay, so that's where. So these are lesions. If you see, you do not treat. Sometimes you will see meridional folds, enclosed oral base, cystoid degeneration, paving stone. You do not need to treat. White without pressure. Do not treat these. These are innocuous. These are normal peripheral retinal signs that you might find, but they are not associated with higher risk of retinal detachment. Okay. Lattice, with or without atrophic holes, cystic retinal tufts, degenerative retinoschisis. There's no evidence that treatment prevents retinal detachment, but you probably may consider treatment, especially if you are not able to follow up these patients for long term. You might advise that operculator tears, definitely you need to distinguish them versus atrophic holes. Generally, they are safe. They do not need to be treated, especially unless occasionally there might be traction around the edges. You may consider treatment of these holes. So symptomatic U-shaped retinal tears, definitely you need to treat. These are associated with sudden floaters and flashes, and 50% of these, as I mentioned, will lead to retinal detachment. Asymptomatic ones, some people may still treat because there is still a small risk of progression, especially if the patient is going to undergo anterior segment surgery, cataract or LASIK. In the evidence of no symptoms, you still might want to treat them. So treatment, of course, with laser photocoagulation using the slit lamp or indirect or transscleral modes. Okay, so depending on your clinical practice, of course, the most convenient is to do it on the slit lamp using nowadays almost all the lesions can be treated with the wide angle viewing lenses, as I mentioned. In some special situations, maybe with patients not able to sit up on the slit lamp, or this, you might consider using indirect ophthalmoscopy with laser attachment and treat that with the indirect laser photocoagulation. Because there's a few years ago they were popularized this transscleral laser, but I hardly see people do that nowadays. So you will use the quadraspheric. Just remember that in our eyes, again, people don't dilate maximally. So you get a good view, much better view with a wide angle viewing lens compared to a 3-mirror lens. If there's mild to moderate cataracts, then you need to increase the technique to get a good reaction in the retina is to increase the power, of course. You can try to decrease the spot size, and of course once you decrease the spot size, the relative power output is increased. You might make the duration longer, okay, and might use diode laser in the infrared, or as opposed to just green laser. Okay. With cryopexy, sometimes it's necessary, especially when there is significant media opacity. It's probably much faster than doing laser, especially you can anesthetize the globe and then do the cryopexy. But of course, it's more traumatic, associated with increased inflammation and breakdown of the blood retinal barrier. So, in summary, as I mentioned, all symptomatic U-shaped or flat retinal tears should be treated. There's currently very little evidence that prophylactic treatment of peripheral retinal degeneration and asymptomatic breaks protect against retinal detachment in the context of anterior segment surgery. Well, basically you should base your treatment on the risk. Again, if you're looking at the fellow eyes, you explain the risk to the patient. If already they have suffered retinal detachment in one eye, you need to educate the patient to be more aware of the symptoms and what are the limitations of treatment, and so that probably you will follow them up, and then so that you can see and treat them whenever there are new symptoms that arise. Thank you very much.
Any questions?
Okay, Professor.